The three main avenues for fertility preservation are ART-IVF, and of course we have heard the nice presentation before, so I'm not going to elaborate on that. Ovarian cryopreservation, and what I will elaborate on is to try and decrease follicular loss by GnRH agonist co-treatment. Well, the ovarian cryopreservation, although 4 babies have been born by now, has a risk of cancer cell which may be reinstituted. And one of the leading centers from Brussels have published 5 years ago 9 women, 21 to 28 years old, after 12 months without pregnancy, after ovarian transplantation of their own ovarian tissue, oocyte retrieval was performed. Out of 21 ovum pickups, empty follicle was in 29%, abnormal immature oocytes in 38%, only 1/4 reached the stage of embryo transfer, and none of them got pregnant. Furthermore, the second leading center from Copenhagen have looked at 72 IVF cycles after ovarian transplantation, 65 oocytes in 72 retrievals. Pregnancy rate less than 7%, and live birth rate only 2.8%. And in an LGI publication, it has been said that concern that the retransplantation of ovarian tissue may possibly reintroduce malignant cells, which is true for leukemia, but not for breast cancer. Or other diseases. Sorry. Well, nevertheless, there are 3 types of diseases are categorized into high risk, medium risk, and low risk. And the lymphomas have been considered to be low risk. Recently, in a reassessment, the non-Hodgkin lymphoma have been moved from the low risk to the medium risk because some cases of ovarian tissue malignancy in non-Hodgkin lymphoma have been published. Hopefully, when we get the slide back, or you can all come and see right here. Yeah, we're few enough. Recently, a Japanese publication of 5,500 women who have deceased from their disease, women younger than 40 years, from various diseases, malignant diseases, have had ovarian, here it is. Non-Hodgkin lymphoma have been moved from the low risk to the moderate risk, and recently, detection of non-Hodgkin lymphoma in ovarian cortex species during cryopreservation have been shown. Even Hodgkin lymphoma, which is still considered a low-risk disease, a recent publication in several years now in fertility sterility has shown that some of the ovarian pieces look completely normal, whereas others are inoculated by malignancy. And ovarian metastases were detected between 8 and 55% in women below 40 years who died of the disease. A huge study of 5,500 autopsy, and even lymphomas who are considered relatively safe have between 4 and 15% risk of ovarian malignancy. Another publication from Copenhagen showing that in 6 out of 8 cases of leukemia, there was ovarian malignancy. Another case of Ewing sarcoma also show ovarian malignancy. Publication Blood from Brussels in Blood Journal from Brussels also shows that implantation of the ovarian pieces to xenograft, to nude mice, have shown that some pieces were normal, the other were full with malignant cells and reintroduce the disease to nude mice. Therefore, we have been, for the last more than 20 years, use a GnRH-agonist as a co-treatment, which is relatively simple, relatively inexpensive, promising preliminary results. However, it is not applicable for radiotherapy. And the rationale behind it is that an ounce of prevention is worth a pound of cure, and the recent publication in Annals of Oncology, our publication, summarizes the pros and cons for this therapy. The only publication where histology have been looked at in primates, obviously it cannot be done in human, was in monkeys. A small group of monkeys have undergone unilateral oophorectomy, after which they were divided in two, one receiving placebo, the other Lupron, and after downregulation, both groups received cyclophosphamide for a year and a half, after which 65% of those receiving cyclophosphamide and placebo lost 65% of their follicles, as compared to less than half, only 29%, with a p-value of significance. So what the GnRH agonist does, it decreases the steep slope by chemotherapy to a less steep, enabling the several primordial follicles, or several hundreds of thousands or tens of thousands of primordial follicles to remain and enable later on pregnancies. One of the 9 published meta-analyses has shown that 93% returning of cyclic ovarian function in the study group, as compared to less than 50% in those without the GnRH agonist, a decrease of 68% in the risk of premature ovarian failure. What's more important, there was a relative risk of 1.65 for pregnancies, not only a decrease in premature ovarian failure, but also pregnancies. And the Cochrane collaboration also shown an advantage, clear advantage meta-analysis for GnRH agonists. The largest prospective randomized study has been published a few years ago in JAMA by an Italian group of 16 centers, having 133 women in the control arm of chemotherapy alone, and almost 150 in the chemotherapy plus triptorelin, having a significant difference in favor of the GnRH agonist for preservation of ovarian function. Until now, we have been treating, in the last 25 years, 289 women for various indications with GnRH agonists in addition to chemotherapy, and combined those to 170 patients without the GnRH agonist. Because they refused, were sent after starting chemotherapy for several weeks or months, or various indications. It was not prospective randomized, because after the first publication in 1996, our oncology colleagues believed it was unethical not to offer it to everybody. So we did offer it to everybody. Until now, we have 166 pregnancies in 81 patients in the study group, as compared to 50 in 27 patients with the statistical significance, 119 newborns as compared to 38, and as I said, 60% pregnancies in the GnRH agonist group as compared to only 42 after long-term follow-up of more than 2 years in those who intended to have pregnancies. Spontaneous pregnancies, some of these pregnancies were by egg donation or by reintroduction of ovarian tissue. So spontaneous pregnancy, the difference is even more significant, almost 60% as compared to 36%, with a very significant p-value. Furthermore, the age at chemotherapy of those who spontaneously conceived was 14 to 38 at the time of chemotherapy in the GnRH agonist group, as compared to less than 28 in those who did not receive the GnRH agonist. In other words, we may possibly extend the fertile window by 10 years. Another recent publication from a year ago of a very large group of patients with breast cancer, both estrogen receptor positive and negative, showing that 71% of those who were interested in pregnancy successfully conceived. The best compliment and support that one can receive is not from his wife, mother, friends, but from his opponents. The German Hodgkin lymphoma group, Caroline Beringer, published in 2010 that the GnRH agonist was not effective in their hands. However, 2 years later on, they published another article showing that not only premature ovarian failure was lost, but fertility itself was kept, was preserved by using the GnRH agonist. Use of GnRH agonist during chemotherapy significantly increased the probability to become pregnant with an odds ratio of more than 12 times. P-value of highly significance. And she apologizes, comparing to the previous publication, we thereby adjusted our analysis to a high degree and nevertheless found surprisingly strong odds ratio of more than 12, evidence supporting the prophylactic use of GnRH agonist. Very recently, about 2 months ago, Cancer Treatment Reviews, Del Mastro and colleague, summarized 9 meta-analyses, all of them of randomized controlled studies, concluding that the significant reduction in premature ovarian failure associated with GnRH agonist co-treatment provides convincing evidence in support of the efficacy of this co-treatment. And most recently, a month ago in the recent ASCO meeting in the States, there was a press conference where the main leading investigator had a New York Times press conference saying that the goserelin, the GnRH agonist used for breast cancer patients, brought about less premature ovarian failure, more births, more babies than women receiving the chemotherapy alone. This NIH-sponsored trial involving more than 250 premenopausal breast cancer patients, 2 years after chemotherapy, only 8% of the agonist co-treatment experienced premature ovarian failure as compared to 22% with the statistical difference. 21% of the GnRH agonist as compared to 11% became pregnant. And what's more important, 15% successfully delivered in the treatment group as compared to 7% with an odds ratio of 2.5 and the statistical P. Unexpectedly, the women receiving the GnRH agonist had a significantly lower risk of dying, so a survival rate was significantly higher in those receiving the GnRH agonist. Not only for malignancy, but also for systemic lupus erythematosus, we can see a publication from the States showing a significant difference between the two groups, and our publication in lupus several years ago showing that those receiving the GnRH agonist, decapeptyl, had cyclic ovarian function 97%, only 3%, 1 of 42 became menopausal, 37 years old lady, and as compared to 40% in the control group. And another publication looking at the AMH showing that those receiving the GnRH agonist had similar mean value and median value of AMH as those who did not receive the chemotherapy, and significantly higher as compared to those who did not receive the GnRH agonist. Until now, for lupus, all the publications show 5% premature ovarian failure in the study group using the agonist as compared to more than 41% in those who did not. What is the possible mechanism? Any alkylating agent, such as cyclophosphamide, would destroy many follicles, especially those that are during active folliculogenesis. Therefore, the estrogen and inhibin will decrease. The FSH, due to the negative feedback, will increase the recruiting and enhance recruitment of follicles being destroyed further on by the cyclophosphamide, and the GnRH agonist administration may possibly prevent the FSH increase. Indeed, some of you will tell that canonically, the primordial follicle are gonadotropin independent, and you are absolutely right. However, they are dependent on activin, bone morphogenic proteins, and GDF9 and others. And these growing factors are secreted by the preantral and antral follicle, which by themselves are gonadotropin responsive. So by giving the GnRH agonists, we prevent the FSH, we decrease the FSH, and prevent the FSH from stimulation of those gonadotropin responsive follicles to secrete the growth factors which will enhance folliculogenesis. And another recent publication also cites that the rate at which follicles leave the resting primordial folds is affected by the presence or absence of the growing follicle. Well, one of the possible mechanisms is to simulate and create a milieu of prepubertal state. And FSH receptors have been found by Tseng and others even in the primordial follicles, which is against the dogma that the primordial follicles are totally gonadotropin independent. Furthermore, another publication of a transgenic mice species with chronically increased LH. When they are born, they have similar number of primordial follicles as compared to wild type. However, as few as 2 weeks later on, their primordial follicles decrease to 45% because of high gonadotropins, and at 3 months, they have 68% less primordial and more than 50% less primary follicles. So high gonadotropins may indeed decrease and be unfriendly to the survival of follicles. There may be also a direct effect, and indeed a group from Japan has showed several years ago that in vitro application of buserelin and other GnRH agonists almost totally in a dose-dependent manner prevented the doxorubicin effect of decreasing the estradiol secretion by the in vitro follicles. Another possible explanation is that the hypoestrogenic state may possibly decrease the ovarian perfusion, thus minimizing the penetration of gonadotoxic chemotherapy to ovarian follicles. This raises the inevitable question whether chemotherapy will penetrate and prevent the eradication of malignancy. Well, actually, the survival in our end, and as published recently in the ASCO meeting, the survival was not less, but even improved by GnRH agonist. Another possible explanation. 10 years ago, Johnson and Tilly from Harvard have published a very equivocal publication suggesting the existence of germline stem cells even in the adult, raising the possible question whether the GnRH agonist may possibly protect such as germinal stem cell. Well, the older of you remember Pygmalion or My Fair Lady, where the Professor Higgins raised the question, why can't a woman be more like a man? So maybe similar to what's happening for spermiogenesis may occur in some mammals. This is highly equivocal. However, not only Professor Higgins, but also Nature raising that question. And a year later on, in the Cell journal, they published that bone marrow transplantation may restore in rodents oocyte production. Whether there is or not the possibility of germinative stem cell being introduced by bone marrow and producing de novo follicles is a very, very large black box with many, many unanswered questions. The only thing I would like to share with you is that in more than 50 patients from ours where we measured the AMH during and after, we have seen that after the 6 months of chemotherapy with or without GnRH agonist, in this case with GnRH agonist, the FSH increased to menopausal level, but after a year, it decreased to normal levels, and many of those spontaneously conceived. And the lower AMH a year afterwards increased to higher AMH, still low but higher, and here it was undetectable, suggesting that all the possible follicles which may secrete inhibin and AMH are destroyed by chemotherapy, and the GnRH agonist may protect germinative stem cell or primordial follicles, which will take them 6, 8, 10, or maybe 12 months to start growing and secreting inhibin, which will decrease the FSH to normal levels and start secrete AMH. So possibly GnRH-agonist may protect this germinal stem cell pool, which is with a question mark. I will almost end by sharing with you a very demonstrative case report. A patient, 14.5 years old, treated by us for non-Hodgkin lymphoma with GnRH-agonist. A year and a half later, she had recurrence of disease where aggressive conditioning has been experienced, again with GnRH-agonist, and bone marrow transplantation. At the age of 24, she married. She had a spontaneous pregnancy, undergone a miscarriage. Few months later on, at the age of 24, she had another spontaneous pregnancy with normal development, fetal sonographic screenings, as we do in Israel, transvaginally at 15, and against transabdominally at 23, normal. However, 3 weeks later on, she was diagnosed with recurrence, starting receiving chemotherapy during pregnancy, and the baby, which was normal until then, undergone intrauterine growth retardation, intrauterine fetal demise. She was the deliverer of a non-viable fetus, and afterwards, consolidation again with aggressive chemotherapy, again with GnRH-agonist, and a second bone marrow transplantation 10 years apart. Nevertheless, 2 years later on, at the age of 28, she had one pregnancy and delivery. 2 years later on, a second one. At the age of 33, a third one. And here you can see the happy patient, happy baby, and of course, happy physician. And here, at her graduation as a PhD in philosophy, you can see the first, the second, and the third baby. We, of course, looked at the literature, and the European group for bone marrow transplantation summarized 19,000 of allogeneic and 18,000 of autologous transplant, having only 0.6% chance of conceiving after one stem cell transplantation. So multiply 0.006 by itself, it will give a chance of about 1 in 36,000 for two stem cell transplantation and conceiving. And our case simulates a report of a 4-year-old patient treated by allogeneic bone marrow transplantation after conditioned regimen containing Oocytes, one of the most aggressive chemotherapy. She had 4 successful pregnancies similar to our patient. Therefore, one of our students summarized all our cases who received GnRH-agonist or not during bone marrow transplantation, and there was a significant p-value in favor of those who received. Of course, it was not 90% like in regular chemotherapy, but even that was significantly higher as compared to premature ovarian failure in those 90% as compared to 62% without or with chemotherapy. Until now, if we summarize the published reports, 13% premature ovarian failure in the various publications using the agonist as compared to almost 50% in those who did not. Until now, there are 20 published publications who are in favor of the GnRH-agonist. In yellow, the prospective randomized one. 2,100 patients in the studies and 8 studies with 509 patients in the studies who were against. Why is this discrepancy? Do I have 2 or 3 more minutes? Why is this discrepancy? For example, one of the leading prospective randomized studies, Zorro study, randomized 60 patients and resumption of 2 menses 6 months after chemotherapy, having 17 zygosorelin, GnRH-agonist group, as compared to 57 in the control. Although the difference is not statistically significant in this, there are many or a long way to go until we'll find the ideal possible material or chemical drug to use in order to preserve fertility. Until then, what I would like to suggest to the young physician of you, if you believe that something is right, don't give up. Thank you very much for your attention.